Good morning, student. So, in the yesterday lecture of the ophthalmology, we was study about the uveitis. In the uveitis, we was studied its classification, anatomical classification, clinical classification, pathological classification, etiological classification, and its various types. That is, infective uveitis, allergic uveitis, toxic uveitis, traumatic uveitis, and uveitis associated with non-infective systemic diseases. Sixth is idiopathic uveitis, its signs and symptoms, its complication and sequelae, differential diagnosis of uveitis, and investigations required for the uveitis. Then treatment, and the next topic is we will learn in yesterday lecture that posterior uveitis. So our today's topic is the other types of the uveitis. In that first one is a purulent uveitis. Purulent uveitis is a suppurative inflammation of the uveal tract occurring as a result of a direct invasion by the pyogenic organism. So, it is the suppurative inflammation of uveal tract and occurring as a result of direct invasion by pyogenic organism. When there is a direct invasion of pyogenic organism which results in suppurative inflammation of uveal tract, which is called as a purulent uveitis. It may start as a purulent anterior uveitis, that is iridocyclitis, or purulent posterior uveitis, that is choroiditis, which soon progresses to involve the retina and vitreous, resulting in purulent endophthalmitis. So, purulent uveitis, it is started as purulent anterior uveitis. So, firstly, there is a purulent anterior uveitis or purulent posterior uveitis, that is choroiditis or iridocyclitis, and which is progressed and involves the retina and the vitreous. So, which results in the purulent endophthalmitis. Okay. Then the next topic is the endophthalmitis. So endophthalmitis is defined as an inflammation of the inner structure of the eye. So there is the inflammation of the inner structure of the eyeball, that is uveal tissue and retina, which is associated with pouring of exudation in the vitreous cavity and anterior chamber and the posterior chamber. So, endophthalmitis, it is the inflammation of inner structure of the eyeball. When there is an inflammation of the inner structure of the eyeball, that is the uveal tissue and retina, with the pouring exudate in the vitreous cavity and anterior chamber and the posterior chamber, which results in the endophthalmitis, that is inflammation of the inner structure of the eye. Etiologically, endophthalmitis may be infectious or non-infectious, that is studied. So, when we see the etiology of endophthalmitis, it may be infectious or non-infectious. Firstly, that is a infective endophthalmitis, and its mode of infections are as follows. That is one, that is exogenous infection. So when purulent inflammation are generally caused by exogenous infection. Due to the exogenous infection, there is a purulent inflammation of inner structure of eyeball is occur following a perforating injury, perforation of infected corneal ulcer, or as post-operative infections following the intraocular operation. So, when there is an exogenous infection which leads to the purulent inflammation, that is, there is a pus formation with the inflammation, and which following the perforating injury. There is a perforating injury, perforation of infected corneal ulcer, or as post-operative infection following the intraocular operation, which results in a infective endophthalmitis. Then, the second mode of infection is the endogenous or metastatic endophthalmitis. It may occur rarely through the bloodstream from some infected focus in the body, such as caries of teeth and generalized septicemia and the purulent sepsis. So, the endogenous or metastatic endophthalmitis it may occur rarely through the bloodstream due to the some infection like caries teeth and generalized septicemia and the purulent sepsis. So this is endogenous or metastatic endophthalmitis. Third one is the secondary infection from surrounding structure. So when there is this infection of the surrounding structure of the eyeball which lead to the secondary infection. So it is very rare, and however, the cases of purulent intraocular inflammation have been reported following the extension of infection from orbital cellulitis, thrombophlebitis, and infected corneal ulcer. So, when there is a purulent intraocular inflammation is occur which is following extension of infection. So infection is extended from orbital cellulitis, thrombophlebitis and infected corneal ulcer which lead to the secondary infection from the surrounding structure and which lead to the infective endophthalmitis. Then the causative organism. In that first is a bacterial endophthalmitis. So, then there is a staphylococcus infection that is from the staphylococcus epidermis, staphylococcus aureus, and other causative bacteria include the streptococci, pseudomonas, pneumococci, and corynebacterium. These bacterial infections lead to the bacterial endophthalmitis. Second is the fungal endophthalmitis is comparatively rare. So from the bacterial it's comparatively rare that is fungal and it is caused by Aspergillus, Fusarium and Candida. So these fungal infections lead to the fungal endophthalmitis but it is a comparatively rare than bacterial endophthalmitis. Then B, that is non-infective sterile endophthalmitis. So in the A, in the infective endophthalmitis, we was study that mode of infection that is exogenous infection, endogenous or metastatic endophthalmitis, secondary infection from surrounding structure and causative organism that is bacterial endophthalmitis and the fungal endophthalmitis. So, in the B, this is a non-infective sterile endophthalmitis. Sterile endophthalmitis refer to the inflammation of inner structure of the eyeball caused by a certain toxins or toxic substances and it occurs in the following situations. So, the sterile endophthalmitis refer to inflammation of inner structure of the eyeball. There is also a inflammation of the inner structure of the eyeball, but it is caused by a certain toxins or toxic substances. It occur as a in following situation. That is, first one, when there is a post-operative sterile endophthalmitis may occur as a toxic reaction to the chemical adherent to intraocular lens, that is IOL, or chemical adherent to the instrument. When there is a post-operative sterile endophthalmitis, that is after the operation, when there is a sterile endophthalmitis, it occurs as a toxic reaction. If toxic reaction is occur due to the chemical which are adherent to the intraocular lens or chemical adherent to the instrument. So when there is a chemical adherent to the intraocular lens or the instrument which results in a toxic reaction and which results in a post-operative sterile endophthalmitis. Okay. Then second is a post-traumatic sterile endophthalmitis. It may occur as a toxic reaction to retain the intraocular foreign body, for example, a pure copper. So when there is a toxic reaction is occur to retain the intraocular foreign body, means post-traumatic is why it is called as post-traumatic, as it is occur after the trauma. When there is a trauma and after the trauma due to the some foreign body like pure copper or any other foreign body which lead to the inflammation of the inner structure of the eyeball, then it is called as a post-traumatic sterile endophthalmitis. It is simple. Then third one is a intraocular tumor. That is, necrosis may present as a sterile endophthalmitis. It is miscreant syndrome. So, intraocular tumor necrosis may be present as a sterile endophthalmitis. Fourth one is a phacoanaphylactic endophthalmitis. It may induce by lens proteins in a patient with the Morganian cataract. So when there is a Morganian cataract with the lens proteins in the patient which lead to the phacoanaphylactic endophthalmitis. So these are the situations where non-infective sterile endophthalmitis is occurred. That is post-operative sterile endophthalmitis, post-traumatic sterile endophthalmitis, then intraocular tumor, and phacoanalytic endophthalmitis. So this is a diagrammatic representation of post-operative acute endophthalmitis. So in that we can see how there is a inflammation of the inner structure of the eyeball, but it is an acute condition and it occur after a operation. Next is clinical picture of acute bacterial endophthalmitis. So, the clinical picture of the acute bacterial endophthalmitis shows the symptom that usually occur within the 7 days of the operation. So, it is a acute. So, all the acute conditions like that bacterial endophthalmitis occur within the 7 days of operation and is characterized by a severe ocular pain, redness, lacrimation, photophobia, and marked loss of vision. So, when there is an acute bacterial endophthalmitis, it is within 7 days of operation and it characterized by a severe ocular pain. There is a severe ocular pain with redness and lacrimation and photophobia with the marked loss of vision. So these are the symptoms that patient told to us and signs that we see in the patient that leaves become red swollen. As patient come in our clinic, we can see that there is a lead become red swollen. Conjunctiva shows chemosis and marked circumcorneal congestion. So there is a redness and swelling of the lid, and conjunctiva shows the chemosis and the marked circumcorneal congestion. So note the conjunctival congestion, corneal edema, hypopyon, and yellowish white exudate in the vitreous seen in the pupillary area behind the IOL. That is, cornea is edematous, cloudy, and ring infiltration may be found. So, in the conjunctival congestion, corneal edema, hypopyon, and yellowish white exudate in the vitreous seen in pupillary area. And cornea is edematous, cloudy, and ring filtration may be found. So, fourth is the edges of wound become yellow, necrotic, and wound may gap in exogenous form. So we can see in this diagram that edges of the wound are become necrotic and yellowish, and wound may gap in exogenous form. Fifth is the anterior chamber shows hypopyon. Soon it become a full of pus. So anterior chamber is full of pus and shows a hypopyon. Iris, when visible, is edematous and muddy. The iris become edematous and muddy. Pupil shows yellow reflex due to the purulent exudation in vitreous, and when anterior chamber become full of pus, iris and pupil details are not seen. So pupil shows yellow reflex due to the purulent exudation. When there is a purulent exudation, due to that pupil shows yellow reflex in vitreous. And when anterior chamber is full of pus, as we see in this uh, fifth, that anterior chamber become full of pus, iris and pupil details are not seen. The next is a vitreous exudation. In the metastatic form and in the cases with the deep infections, vitreous cavity is filled with the exudation and pus, and soon a yellowish white mass is seen through the fixed dilated pupil. This sign is called as the amuretic cat's eyes reflex. So, in the vitreous exudation, that is in metastatic form, and in the cases with the deep infection, the vitreous cavity is filled with the exudation and pus, and soon a yellowish white mass is seen through the fixed dilated pupil. So, through fixed dilated pupil, the yellowish white mass is seen. That is, in this diagram, you can see how there is a vitreous exudation showing the yellowish mass. So this is sign is called as ameretic cat's eye reflex. Next is the intraocular pressure is raised in early stages, but in severe cases the ciliary processes are destroyed, and a fall in intraocular pressure may ultimately result in the shrinkage of the globe. So when there is an increased intraocular pressure, but in severe cases, ciliary processes are destroyed. When there is a severity is increased, the ciliary process is destroyed and fall in intraocular pressure. So which result in a fall intraocular pressure and ultimately result in a shrinkage of the globe. Then there is a shrinkage of the globe. So this is a severe post-operative endophthalmitis with the wound gap. As we studied that there is a post-operative endophthalmitis shows a wound gap. So this is a diagrammatic representation of this. Then the treatment. An early diagnosis, a vigorous therapy is hallmark of the treatment of endophthalmitis. That is, a antibiotic therapy in that Intravitreal antibiotics and diagnostic tab should be made as early as possible. And second, that is the subconjunctival injections of antibiotics should be given daily for 5 to 7 days to maintain a therapeutic intraocular concentration. Third one is a topical concentrated antibiotics should be started immediately and used frequently every 30 minutes to 1 hour. Fourth is the systemic antibiotics and B, that is steroid therapy, which is used after 24 to 48 hours. So, early diagnosis and vigorous therapy is a hallmark in the treatment of endophthalmitis. In that, we can use antibiotic therapy and steroid therapy. And in the antibiotic, there is a intravitreal antibiotics and diagnostic tab. And in conjunctival infection, conjunctival infection, third one is a topical concentrated antibiotics, systemic antibiotics, and steroid therapy, but which is used after 24 to 48 hours. Then the supportive therapy. In that, first is a cycloplegics, preferably 1% atropine or alternatively 2% hematotropin eye drop should be instilled TDS, that is thrice in a day, or QID, that is 4 times in a day. Second is an glaucoma drugs, that is in a patient with the range intraocular pressure drugs such as the oral acetazolamide, that is 250 mg TDS, and timolol, that is 0.5% BD, may be prescribed. D, that is the vitrectomy. Operation should be performed if the patient does not improve with the above intensive therapy for 48 to 72 hours. So this is very important. Where due to the above therapy, the patient condition is not improved for 48 to 72 hours, then or when patient present with severe infection with visual acuity and reduced in light perception. Then vitrectomy is essential. So vitrectomy helps in removal of infective organism, toxin and enzyme present in the infected vitreous mass. So for the removal of infective organism, toxins and enzymes present in infective vitreous mass, vitrectomy help to patient. Then next topic is a panophthalmitis. हॅलो स्टुडंट, तुम्ही सगळ्यांनी जर्नल कंप्लीट केले का? हॅलो, आन्सर मी. रेपट्रीचे जे सर आहेत सुश्रुत सोमन सर, त्यांचा कॉल आला होता मला. तर ते म्हटले की तुमच्या ज्या केसेस आहेत 10 ॲक्यूट 10 क्रॉनिक ज्या तुम्ही जर्नल्समध्ये लिहिलेल्या आहेत त्याबद्दल तुम्ही त्यांच्याशी बोलून घ्या रेपट्रायझेशन विषयी. हॅलो, ऐकू येतंय का मी काय म्हणते ते?
ओके मॅम, पण अजून कम्प्लीटच नाही आहेत आमचं.
मग कधी कंप्लीट करणार आहे तुम्ही?
मॅम आधी जर्नल घ्यायचे आहेत कॉलेजला जाऊन.
हॅलो,
जर्नल्स घ्यायचे आहेत मॅम अजून.
जर्नल घ्यायचे आहेत. मग तुमच्यापैकी एका स्टुडंटला तर मला मागे विचारलं होतं जर्नलमध्ये कसं काय कम्प्लिशन.
यस मैम 3-4 केस लिखी हम लोग ने.
ओके, तर
हेलो मैम.
हॅलो, हां बोला.
मैम हम लोग ने लिखे 3-4 केस, आपने पहले ही बोले थे ना.
हाँ वही तो सोमन सरांचा मला कॉल आला होता. मराठी सगळ्यांना समजतंय?
यस मैम, यस मैम.
तर सोमन सरांचा मला कॉल आला होता. काल प्रिन्सिपल सरांची पण नोटीस आली आहे आणि आता गणेश शिंदेंनी पण टाकलेलं आहे की सुश्रुत
यस मॅम.
सोबत तुम्ही कॉन्टॅक्ट करा सर्जरीचे केसेस रेपेट्रायझेशन विषयी, कारण ते ज्या जर्नलसाठी इसेन्शियल आहे, जे तुम्हाला एक्झामसाठी इम्पॉर्टंट आहे. आणि तुमची एक्झाम आहे ना मार्च फर्स्ट वीक पासून.
यस
हो
मॅम.
मॅम.
तर तुम्ही डिसेंबर एंड पर्यंत जर्नल कम्प्लीट केलेच पाहिजे. हम्म? तर तुम्ही
हा मॅम.
डिस्कशन करा सगळ्या स्टुडंटने, आताची जी बॅच आहे तुमची थर्ड विंटर 2020, आणि एक रिप्रेझेंटेटिव्ह कोणीतरी चूज करा आणि सोमन सरांशी बोलून घ्या रेपट्रायझेशन विषयी. प्रत्येक केसेसचं अनालिसिस, इव्हॅल्युएशन आणि रेपट्रायझेशन ॲक्युरेट करा, कारण एक्झामिनर हेच विचारतात ओरलमध्ये. ओके,
हा मॅम. हा मॅम.
ठीक आहे. सो
हो
लेट
हो.
अस कंटिन्यू विथ द पॅन ऑफ्थॅल्मायटिस. Panophthalmitis is defined as it is an intense purulent inflammation of the whole eyeball, including the tenon's capsule. And the disease usually begins either as a purulent anterior or purulent posterior uveitis, and soon a full-fledged picture of panophthalmitis develops, following through a very short stage of endophthalmitis. So, panophthalmitis, it is an intense purulent inflammation of whole eyeball, including tenon's capsule, and begins either as a purulent anterior or purulent posterior uveitis, and soon a full-fledged picture of panophthalmitis develops, following through a very short stage of endophthalmitis. So, when we see the etiology of panophthalmitis is an acute bacterial infection. The mode of the infection and causative organism are same as described for infective bacterial endophthalmitis. So, panophthalmitis is acute bacterial infection, and mode of infection and the causative organism are same as the infective bacterial endophthalmitis. Symptoms include the severe ocular pain, headache, complete loss of vision, profuse watering, purulent discharge, and marked redness with the swelling of the eyes, and associated constitutional symptoms are malaise and fever. So, the symptoms that patient feel is that there is a intense ocular pain, headache, loss of vision, profuse watering, purulent discharge, and marked redness, swelling of eyes with malaise and fever. And signs that we see in the patient that leads shows a marked edema and hyperemia. Okay? So this is a diagram of panophthalmitis, in that we can see how the lid shows a marked edema and hyperemia, with the eyeball is slightly proptosis and ocular movement are limited and it's very painful. Conjunctiva shows the marked chemosis and ciliary as well as conjunctival congestion. So there is a ciliary and conjunctival congestion. Cornea is cloudy and edematous. Anterior chamber is full of pus. Cornea is cloudy edematous and anterior chamber is full of pus. Vision is completely lost and perception of light is absent. Intraocular pressure is markedly raised and globe perforation may occur at limbus. Pus comes out and intraocular pressure falls. Complications include the orbital cellulitis, cavernous sinus thrombosis, and meningitis, or encephalitis. So, say in panophthalmitis, there is a leads are edema, shows edema, hyperemia, proptos, eyeball, and ocular movement are limited, painful, weak. Conjunctival shows a chemosis, ciliary and conjunctival congestion with the cloudy and edematous cornea. Anterior chamber is full of pus and vision is completely lost and perception of light is absent. So intraocular pressure is raised. There is a globe perforation at the limbus and pus is come out. So complications include the orbital cellulitis, cavernous sinus thrombosis, meningitis, or encephalitis. Then the treatment of panophthalmitis, in that there is a little hope of saving such an eye, and the pain and toxemia tend to urgency to its disease. So first one is anti-inflammatory and analgesic should be started immediately to relieve the pain. So anti-inflammatory and analgesic should be started immediately to relieve pain, and broad spectrum antibiotics should be administered to prevent a further spread of infection in the surrounding structures. So broad spectrum antibiotics is needed with anti-inflammatory and analgesic. Evisceration, that is, operation should be performed to avoid the risk of intracranial and dissemination of infection. So, evisceration operation is required in cases where to avoid the risk of intracranial dissemination of infection. So, in the treatment of panophthalmitis, anti-inflammatory drugs and analgesic used to relieve pain, then broad spectrum antibiotics should be administered to prevent the further spread of infection in the surrounding structure. Then evisceration operation should be performed to avoid the risk of intracranial dissemination of the infection. So, in the Panophthalmitis, we seen its definition, etiology, clinical picture, signs and symptoms, and treatment. So, next is the specific clinico-etiological types of non-suppurative uveitis. In that, classification shows when uveitis associated with a chronic systemic bacterial infection. In that, first one is a tubercular uveitis, syphilitic uveitis, leprotic uveitis. When it is uveitis associated with the chronic systemic bacterial infection. And second is when uveitis associated with the non-infectious systemic diseases like uveitis in sarcoidosis and Behçet's disease when there is a non-infectious systemic disease. Then third is when uveitis associated with the arthritis, that is uveitis with ankylosing spondylitis and Reiter's syndrome and Still's disease. So this is uveitis associated with the arthritis. Then parasitic uveitis, in that toxoplasmosis, toxocariasis, onchocerciasis and amoebiasis is included in parasitic uveitis. Uveitis contain presumed ocular histoplasmosis syndrome and candidiasis. So this is a fungal uveitis. Viral uveitis contain, that is herpes simplex uveitis, herpes zoster uveitis, acquired cytomegalovirus uveitis, and fourth is uveitis in acquired immune deficiency syndrome, that is S. So this uveitis is occurred due to the virus. Then it is called as the viral uveitis. Next is a lens-induced uveitis. In that there is a phacotoxic uveitis and phacoanaphylactic endophthalmitis. So this is a lens-induced uveitis. Next is a traumatic uveitis, and ninth is a uveitis associated with malignant intraocular tumor. Last is idiopathic specific uveitis. So this is the classification of specific clinico-etiological types of non-suppurative uveitis. The syndromes in that, which is uveitis syndrome, intermediate uveitis, that is a pars planitis, sympathetic ophthalmitis, glaucomatocyclitis crisis, oak Carnegie Heradas syndrome, birdshot retinochoroidopathy, then acute multifocal placoid pigment epitheliopathy, and serpiginous choroidopathy. Next is a tubercular uveitis. Tubercular uveitis is a chronic granulomatous infection caused by a bovine or human tubercular bacillus. It may cause both anterior and posterior uveitis, and at one time it is very common and it is now becoming a rare cause. It accounts for 1% of uveitis in developed countries. However, in developed